Welcome to Health Hour, a session for you by Black doctors, hosted by the Caribbean and African Health Network. Ever sat in a doctor's office thinking, they just don't get it? Or search for health advice online, but you can't understand it? Felt unheard? You're not alone, and you found your solution with Health Hour. Every Saturday at 11 a.m., this is your space where Caribbean and African healthcare professionals speak about health with a focus on Black people. We tackle the topics that keep you up at night: mental health, chronic conditions, preventive care, sexual health, men's health, women's health, heart disease, and much more. All with a cultural context that matters, because our Black doctors understand the unique challenges we face. Here is what you can expect: real talk from doctors who look like you and get it, lived experience testimonies, practical advice, illness prevention and management tips, and a space of understanding without judgment. You also get to ask questions. Your questions drive the conversation. Health Hour, where community meets Black health expertise.
Good morning, everyone. Lovely to be here once again, and welcome to Khan's Health Hour. My name is Dr. Vanessa Apea, and I am a consultant in sexual health and HIV, and it is my pleasure to be with you today. And I want to give a huge welcome to our regular listeners. I can always see familiar names when I come on to host, and always people getting in contact during the week. So I want to actually appreciate everyone that does do that. So thank you, thank you. But also, I really want to welcome those who are spending time with us for the first time. And today we've got quite a global speaker list. And so I won't spoil some of the surprise of where one of our speakers is speaking from, but it would be wonderful to hear from you as to where you're tuning in from, what part of the UK or internationally, and also if you are tuning in alone or you're sitting with other people as well. So just a reminder of what Health Hour is, and essentially Health Hour is for you. It is a collaborative, educative, and empowering health literacy program that has been created by Khan to ensure that you get the information that you need to essentially live your best life in health. And it's also an opportunity for you to listen, but also to share to friends and family and other people in your network that may not be able to listen right now. But we are on all the social media platforms, and you can share the YouTube link, which will be in the chat, to others so that they can watch later as well. And the other thing is that we've curated our list of topics, but if there are any potential topics that you would want covered, please do share it in the chat as well. So really looking forward to interacting with you on the chat. Today we have I always say each episode that I host is special because every individual comes and shares their knowledge and imparts as well. So every health hour is special. But today we have an eminent speaker who will be sharing about a really important topic related to chronic kidney disease. But then we're also so fortunate to have someone with lived experience and has a really unique intersection of being a clinician, being in ministry, and also lived experience as well of a kidney transplant. So I will be introducing them as we go along, but please use this opportunity to call friends and family and let them know that we've got a great health hour in store today. So with no further ado, I want to introduce Professor Ibi, who I'll let you know I'll let him tell you where he's joining from. But Prof. Ibi is a renal physician and a clinical academic and currently working as a consultant in renal medicine. He's also an honorary senior clinical lecturer at the University of Manchester and visiting honorary professor of medicine at the University of Port Harcourt in Nigeria. So we are really, really fortunate to have him here. So Prof. Ibi, thank you so much for being here, and over to you.
Thank you very much, Vanessa, for the kind introduction. like I said before we started, that I'm making this call from Nigeria. I'm on an academic visit to the University of Port Harcourt. So so you know what some of the issues are in terms of network here. So if I have a blip, just please understand that it's coming from Nigeria. It's quite stable at the moment, but we'll have blips. So I'm just giving you that pre-warning, and I apologize in advance. So I'll just share my slides, and just to mention that if you can see my slides. Oh no, just one second. Just. Right. So if you can see my slides, could you just give me a thumbs up?
Great.
Okay. All right. So I'm a kidney doctor. I've been in renal medicine for 2.5 decades. So I'm also into medical education. So today I'll just talk about CKD, which is chronic kidney disease, what you need to know. So I'll try and make it as with less jargon as much as I can. And so just to start with, I want to just remind you of what the kidneys look like in health. And what is CKD, which is chronic kidney disease, and the risk factors, symptoms, and stages of CKD, and prevention and treatment, and takeaway messages. So just as an introduction, the kidneys are two bean-shaped organs, and it's just about the size of your fist. But what is interesting is that there are powerful chemical factories, and so it enables you to balance your chemicals in your body and get rid of toxins and unwanted chemicals at the same time. The other interesting aspect is that each kidney has 1 million filters. We call them nephrons. They are responsible for filtering the toxins and keeping keeping the wanted ones and getting rid of the ones that are not wanted. So this is just a kind of just to give you a pictorial view of the kidneys. And so you could see that it weighs slightly bigger in the males and compared to females. The size is just about 10 to 12 centimeters. And what is interesting that I want you to take home with is that in a normal 24-hour period, you have 800 mils to 2 liters per day, which is normal fluid intake of about 2 liters. So that's what the urine comes out, the urine volume. So sometimes when people just ask me that I'm not passing enough, if you're not drinking enough, you're not going to pass much. So these are the filters that I talk about that are regularly worm-like things. This is what it looks like, the filters. A tiny microscopic, you can just view them under the microscope. So if you cut a section of the kidney here and you just look at it under the microscope, this is what you're going to see. So just to remind you that blood enters the kidneys and is filtered. You can see I just made this pictorial this cartoon so that you'll be able to understand. It filters it, and then urine collects in the collecting system here, and is now stored in the bladder. And when you feel like voiding urine, you just go and pass urine. So this is the same thing. Filters, there's a lot of things that go on in the filter, and finally urine comes out. So I just want to give you this background of the kidneys in health. So what does it do then? It ensures that there is balance of water in your body, not too much, not too little. It's the seat of blood pressure control, and it ensures that you get rid of waste, toxins, which I alluded to in my earlier slide. But the other thing that you should understand, apart from those filtration things, the kidneys are very key to ensuring bone health. It activates both vitamin D, helps the body to absorb calcium, which helps the body to absorb calcium. And it balances the acid and base in your body so that there's not too much acid or alkaline. And with the acid-base balance and ensuring that the body salts are kept well, your heart functions well, and goes into normal reading with the various salts like potassium, sodium, and calcium. The other thing that is very important that the kidney does is to ensure that it produces a chemical that stimulates your bone marrow to produce red cells. So you can see that the kidneys, apart from making urine, does a lot of other things. So that's why when people have kidney disease, they're usually sick. Most of these things don't work properly. So what is chronic kidney disease then? The term chronic kidney disease suggests that it's a lasting damage to the kidneys that gets worse over time. So by the time a patient gets end-stage kidney disease requiring dialysis or kidney transplant, the kidneys look like fibrosis, which like scars. There are scars all over the kidneys. So that meant that kidneys will not be able to filter blood the way they should, which I've shown in the previous slide in a normal kidney. And so there is progressive loss of the filters, which occurs for many years. So medically, when patients come to see us, the way we look at definition of kidney disease, chronic kidney disease, is that there is some abnormality of the kidney function or structure present for more than 3 months. That's the way we think. So once you have this, we will diagnose you as having CKD, which is chronic kidney disease. So this is what I've said about CKD, greater loss of kidney function, but there are symptoms of the kidney function as the kidney damage gets advanced, and it common causes of kidney disease are diabetes and high blood pressure, which you should bear in mind. The diabetes is the commonest cause of kidney disease worldwide. And when you have end-stage kidney disease, which is when your kidney damage has gone advanced to a point that is incompatible with life, then they will offer you dialysis or kidney transplant. So how common is it? And that's what is quite interesting to us as kidney doctors. So it's a leading cause of public health. It's a leading public health problem worldwide. 50 million individuals suffer from progressive kidney, and this is data from the WHO, World Health Organization. And so it is estimated that the prevalence, which is what the occurrence, what is existing that presently is about at 13.4% when you compare to the world population. So more than 1 in 7 people, mostly in the for example, 15% in the US, have CKD, and majority of them are African Americans. But in the UK, 3 million people live with CKD. This is data from both the Kidney Care UK and the UK Kidney Association. So, but in the entire African continent, the prevalence is around 10.1%. This is ISN, International Society of Nephrology data. And in Nigeria, the prevalence is between 1.8 to 43.5%, depending on the study population, because most of them are hospital-based studies. So you can see that it's a disease that is common although silent. So in the UK, just a bit more details. 63,000 people in the UK are being treated for kidney failure, which meant that kidney function is functioning less than 15%. But I just want to bring your attention to the alphabets written in red. The Black, Asian, and minority ethnic communities are 5 times more likely to develop CKD than other groups. And so that's something that you should be aware of. And so these are the things that the risks that cause kidney disease, which I've mentioned before. Diabetes, high blood pressure at the top. Diabetes is number 1. Heart disease is closely associated with kidney disease. Obesity, which is linked to high blood pressure and diabetes. smoking. But as you grow older, after age 40, usually you lose 1% of your kidney function. Does not mean that you have kidney disease. But if you have kidney disease, if you have any of these ailments, when you're above age 60, your chances of having kidney disease is high. And so these are the top 3 that cause kidney disease, which I've mentioned before. I'm not going to bore you with all the others. Just know that type 2 diabetes, high blood pressure, and inflammation of the kidneys due to infections or immunological causes are the 3 main causes. So I just put it in pictorial so that you can picture it. But I just want to mention that the commonest genetic cause is when you have polycystic kidney disease, which is a kind of transmitted from parents to their children, and it's usually autosomal dominant. That means that if you have the genes, 2 of the genes from both parents, you will likely to have the disease. So I put this together so that you understand that all of these 3 cycles are intertwined: diabetes, hypertension, and chronic kidney disease. And this is something that I say time and time again. And so when you begin to approach, how do you prevent or manage it? You manage the key risk factors, then you have a reduction in chronic kidney disease. So there's no magic drug, although there are drugs that we give to reduce the progression of kidney disease caused by these 2 risk factors, but you can prevent it from the outset if you manage your diabetes well and your blood pressure is under control. Just to mention that when you have chronic kidney disease, you have heart disease. The kidney disease is a multiplier of your cardiovascular disease, which means that patients who have chronic kidney disease do not die of kidney disease itself, they die of heart disease, because it multiplies your chances of mortality, which is death, when you have kidney disease. With the risk factors I mentioned before. So this is just the difference between a healthy kidney and a chronic, and just one of the causes, which is diabetic kidney disease, which is the commonest cause. You could see that this is the filter, that everything is going well. So the filters are not leaking any protein, but if you look at the diseased kidney here, the filters are now all, we can see that damaged, and you begin to leak protein, and the protein itself causes further damage in the urine. And so what we do as kidney doctors is to reduce the protein in the urine and ensure that and the drug will be able to maintain the protein in the blood so that it doesn't leak into the urinary space to cause further damage. Now, I just want to make you aware that, especially if we from the ethnic minority groups, that over-the-counter medications, especially those that are came from globally, the ethnic minority groups, some of these over-the-counter drugs have some effects, especially non-steroidal anti-inflammatory agents and some other medications. And I've noticed I've been in Nigeria for over 10 days trying to do some academic work. And a lot of people are taking all sorts, especially advice from the internet. People are taking all sorts that they buy from all over the place. And people have been alluding to the fact that it will cure your kidney disease, and you should be aware of that. And so how does herbs affect the kidneys? I've had people, my patients, who I just don't see them after a while in the UK, especially some of my Nigerian patients, they've been advised to take some herbs, and by the time I see them, their kidney function probably has dropped by over 20 to 30%, because they've been taking something that was advised by either relatives or friends to take these herbs. And you could see that these herbs have effect on the filters and damage the membranes of the filters in the kidneys, which I've shown you before. And just to let you know that most of these habit of herbs and things happens in sub-Saharan Africa, India, China, Latin America, and the Caribbean. And so this population, if they're in the UK, they're likely to be the ones to be taking some of these herbs and things like that. Although I've had some of my Caucasian patients who have been taking some of this medication. So this is what the kidney looks like in chronic kidney disease. You can see this healthy, nice pink kidney, and you can see this is shriveled, and it's all filled with scars and all that. So that's the way the kidney looks like once your kidneys have gone advanced with kidney disease. As I've shown this before, healthy kidney, and inside, I just want you to get a pictorial view of what happens why that kidney is shrunken. This is what happens in it. The filters cannot hold some of these things anymore, and they just get lost in the urine, especially protein, which causes further damage to the filters. And so this is for our own information. I mean, doctors, especially kidney doctors, we try to stage kidney disease into 5 stages. This is to help us to be able to help our patients. And this classification has come up over the last 30 to 40 years. So stage 1 is when your kidney function is still working at 90%, stage 2, 60 to 89%, stage 3, 30 to 59%, stage 4, and stage 5, which is less than 15%, in which case we'll begin to, the kidney can no longer keep up with removing waste products and extra water. And then you go into end-stage renal disease, which is established kidney failure. And so this is the same thing. I just want to break it down. And so my kidney damage, my kidney still works well up until 60%. And then once it gets below 60%, then don't work as well as it should do. Then it goes down, and then gets to more severe damage, and you need support. And dialysis and transplant don't take place until the kidney function is less than 10%. Or to begin to prepare you when kidney function is less than 15 to 20% for either dialysis or kidney transplant. So this is the same thing. I'm just mapping this to the kind of symptoms you get. So stages 1 to 3, most times there's no symptoms. When the late stage 3, you begin to have some symptoms. You feel a bit fatigue, or you get foamy urine because of protein in the urine. And then stage 4, stage 5 is when you begin to prepare for dialysis. And so these are some of the symptoms of advanced chronic kidney disease, when your kidney function is beginning to work less than 20%. And you get some of these symptoms. Nausea, vomiting, tiredness, loss of appetite, and fluid retention, and bubbly urine, and all that. These also have sleep disturbances. So for those that have risk factors, like you have diabetes, hypertension, or you've had a previous history of inflammation of the kidneys, these are the ways that we diagnose your kidney kidney disease by doing blood tests, in which we estimate the toxins in your blood, which is called urea and creatinine, mainly, which we use to assess kidney function. And then we use that to calculate the percentage of loss of kidney function. And then we need to do an ultrasound scan to look at the size and appearance of the kidneys. And that gives us an idea whether the kidneys are getting smaller, shriveled, which I showed in the previous slide. And then sometimes when you have a diagnostic dilemma, which we're not sure what's going on, we do a kidney biopsy. That means we take a little pinch of the kidney tissue from your kidneys to look under the microscope to give us an idea, especially when we encounter cases where there's inflammation of the kidneys, or when patients leak a huge amount of protein, we're not sure. We do a kidney biopsy, and then the urine test is to assess your protein level in the urine, which will guide us with some treatment, because there are medications that can reduce the protein in the urine. So we regularly test your urine test. Your urine for protein, especially when you have diabetes. One of the things your doctor is supposed to do even in primary care is to test your urine for protein and to see if you're leaking loads of protein. Well, that may be just an indication that your kidneys are not working. Your filters are beginning to get damaged. So this brings me to the prevention and treatment of CKD. So the first point I want to make here is that there's no cure for chronic kidney disease. And the treatment is to help relieve symptoms and stop it getting worse, which I will explain a bit further. Treatment will depend on the state of your kidney, this chronic kidney disease, which I've showed in the previous slide, which is from stages 1 to 5. And so the main preventative measures you can see is something that you can do yourself if you're proactive about your health, is managing the risk factors, regular medical checkup, especially when you're above 40, especially in our Black population, where most people have family history of high blood pressure and diabetes. And then your lifestyle changes. So it's still something that you can handle working with your primary care physician. And so I put this slide so that you be aware that dialysis and transplantation comprise a visible, expensive component of care, but we can do something to make you not end up on the visible care, on the visibility that I'm showing you in terms of dialysis and transplant. So what do we do? So you're preventing chronic kidney disease. There is this adage that says an ounce of prevention is worth a pound of cure. So your diet and exercise to maintain a healthy weight, smoking cessation, control your diabetes, blood pressure, and cholesterol, and avoid excess over-the-counter medication, ibuprofen, and some of these herbal preparations, and do regular checkup with your primary care physician. So just going back, I just want you to be aware that what we're saying, those that have dialysis and transplant, those are the visible things, and those are what people see. But what of those that have the disease and not looking after themselves properly, or not working with the doctors to reduce progression of the disease? So that's very important. It's a good take. It's a very valid take. A very important take-home message. So what do we do to prevent or slow? So you take your medications for your diabetes, high blood pressure, managing changes in your eating diet, salts and other things, lifestyle changes. For diabetes, you manage your glucose well, losing weight, getting regular physical activity. So these are things that we can proactively do, not passively. And so we can proactively look after ourselves in conjunction with our primary care physician before your kidneys get to a point that they refer you to the kidney doctors. So I just want to put this, which is busting the myths of hypertension, which is something that affects our people, especially Black population. Now, the first point is hypertension is not a temporary illness that will resolve. And the second point is that the absence of symptoms like headaches and dizziness does not mean good hypertension control. So there is no need to experiment with stopping your medication, because it's not something that any of these infections or bacterial, those that are in sub-Saharan Africa or the parts of the low and middle income countries, malaria, you need to continue to take your medications. Do not stop medication because of lack of symptoms. And then do not wait for symptoms before you take your medication. And the other point is that long-term medication is not harmful, that some people are looking to on the internet and on YouTube. But you should also know that every medication has side effects, but you can work that out with your primary care physician, who will be able to liaise with whoever expert is there to give you the medicine that you can tolerate. So dependence or the drug building up to harmful levels is not something that we encounter, although some people will have some side effects, which we can discuss and manage those side effects. So alternative medicines like herbal medications are not more effective, but may result in further complications, and too little, too late. So I'm just putting this so that you're aware. That's why I always put this slide when I'm giving talks on CKD, busting a medicine hypertension. So what do we do in slowing progression of CKD? We treat risk factors, diabetes and hypertension, to reduce the protein in the urine. There are medications that are available. In fact, right now, there's a newer medication that is available, which I said in my lifetime, as a kidney physician, those medications are now available and can reduce progression once you have the disease. So that meant that you have to be proactive working with your kidney doctor if you've been referred, and modification of lifestyle, avoid the things I've mentioned before, avoid over-the-counter drugs and herbal preparations and regular checkups. So the same thing that I've said in the previous slide, and there are newer therapies which I've said to some of these therapies are still being tested that make progression of kidney disease faster among the Black ethnic group. Because of that, there are therapies that were targeting at genes, and one of them is apolipoprotein. It's not something that you should know about, but just know that some therapies are coming up now, especially among Black ethnic population. So this is what happens, and this is where we don't want anybody to be. Once you get to end-stage kidney disease, we begin to prepare you for kidney transplant and dialysis, which is the renal replacement therapy that you see on the slide. And so we'll begin to manage other things. You see, when I showed you the slides of when the kidneys are in health, they talk about diabetes, you talk about anemia, your fluid retention, you have problems with your bones, and all these other things begin to creep up. So you need to manage that, especially when your kidneys are damaged in advanced state. So this is what I just put this cycle. When you are get to this stage, we will offer you dialysis, and two types of dialysis. One is peritoneal dialysis, which is done through the tummy, and hemodialysis, which they take your blood through from your vein, put through a machine, it cleans it up and brings it back to your body. And the gold standard for treating chronic kidney disease long term is kidney transplant. And so this is the peritoneal dialysis. This is just a cartoon of it. I just wanted to just give you an idea what it is like. It's not a pleasant thing. It chips in your tummy, which is now functioning as a filter. The membrane in your tummy behaves like a filter. So this is peritoneal dialysis. Whether I give you this or we give you hemodialysis, in which your blood goes into this machine and cleans it up and brings it back to you. And so this is a kidney transplant. We don't remove the diseased kidneys. We just put your kidney in your groin, and then except where your kidneys are too big that we can't put this kidney, then we'll need to remove the kidney to put this kidney. And the other reason too that we remove kidneys is when your kidneys have infection, so that you don't infect the transplanted kidney. So in summary, your kidney health is made up of many things: lifestyle. You talk about the risk factors with diabetes, hypertension, and all that. But one thing that I want to emphasize is the compliance to your treatment of those risk factors like diabetes, hypertension. Take proactive be proactive with your lifestyle and all that. So just to give you a picture of all the things I've been saying in the last 15, 20 minutes. So what are the take-home messages today? So CKD, CVD, which is cardiovascular disease, they are all very common and interrelated. I showed you with the cartoon. If you have chronic kidney disease, you have diabetes and hypertension, your chance of heart disease is very high, and most patients likely die from heart disease than anything else. And I also mentioned that lifestyle is a poor diet, lack of exercise, tobacco use, excessive alcohol are significant risk factors, which causes other things, obesity, hypertension, and all that. So, and prevention is the key. I did mention that. An early detection of MMedSc is essential to slow the progression of chronic kidney disease. And health check with your primary care physician is important to screen for and manage these diseases. So these are the take-home messages for this talk. And so how do we keep our kidneys healthy then? These tips can help keep your kidney health on track. Regular physical activity, lose weight if you need to. Eat less fat, keep your blood pressure, blood sugar, and blood fats under control. Stop smoking, keep well hydrated. Be cautious, and if possible, avoid above medications and over-the-counter medications that are not going to be injurious to your kidneys. So those are the things that I want you to take home. how do you keep, so you can see that it's not rocket science. It's not something that is complicated. Thank you very much. And I'll entertain questions. Thank you.
Thank you so much, Prof. Ibi. That was fantastic as always. But you always know when people are learning and want to learn more by the questions that are coming through, and they are coming through thick and fast. So thank you. And I think one of the things that was definitely really pivotal as well, that you added in about the myths about hypertension as well, because we all know that all of those are floating around everywhere. So thank you for giving such a great overview of kidney disease, but also about the myths of hypertension as well, that we can all share with our family and friends, because I'm sure many of us have heard them. And so I said there's many questions, and as ever, I will try as much as possible to filter them all as much to Prof. Ibi. But as I did also say earlier, this is a really special edition of Health Hour, because I now want to bring on Dr. Nosa. And Dr. Nosa is a consultant anaesthetist and a senior medical educator, and he's also been active in Christian ministry. And he will be speaking from his lived experience. And I've just got a few questions just to get things going, because he has had a very successful kidney transplant. So we've gone from understanding that progression to the options that are available that Prof. Ibi has presented. But then we're really fortunate to have someone with that lived experience to share. So Dr. Nosa, thank you so much for coming on. A huge privilege to have you here. And I just wanted to see if your camera is on. Perfect.
Yes, it is on. Yeah.
Lovely. So thank you so much for taking the time to be with us. I can see that you've actually got some slides as well. So perhaps I'll let you talk through those, and then I will just go through some of the questions as well.
Well, thank you very much. It's a privilege to be here today. I want to thank Professor Ibi for so eloquently explaining a very complicated topic to make it as easy as possible for people to understand. And that's where I really want to start from, because having an insight into your condition does help you to actually cooperate and know what is happening to you, know when to seek for help. So what I'll first of all do, my own background is that, yes, I'm a doctor. In fact, this is my 47th year in medical practice. And I'm not a kidney specialist. My only association with kidney issues is in intensive care, because we do hemofiltration, we look after patients. And as an obstetrician, prior as an obstetrician, I was in maternal medicine, and we looked after a lot of high-risk pregnancy women with kidney conditions related to PET. But apart from that, I'm just a layman like everyone like you. So I will go through the questions. The first question here says, could you tell us about your journey to being diagnosed with kidney disease? Now, my own journey, I was an accidental diagnosis. I went for health check. It was a pre-employment check over 20 years ago, and they found asymptomatic proteinuria, which was quite mild at the time, but we were a bit concerned why was that. And then I was completely asymptomatic. I didn't really have any. I didn't know that was there. So we did a biopsy at the time, and we found out that I have what a FSGS, which is basically one of the diagnoses that lead to kidney problems. So, but over the next 20 years, nothing really happened. We just controlled control my blood pressure. I still have my proteinuria, and there were just no issues at all. But then at about the time of COVID, I got I got into trouble. I had COVID, and there was an accelerated deterioration in my kidney function, and then leading on to dialysis, and for about 2 years, and then going on to a successful transplant, for which I'm eternally grateful to the donor and to those who were involved in my care. So that's so then the next question was, what was your day-to-day life living with CKD before your transplant, and what helped you cope practically and emotionally? Yeah, practically, I'm one of the very lucky ones that most of the time I was well. I engaged a lot, and I'm quite pleased that Professor Ibi emphasized that the need to cooperate with your carers, and to follow instructions, not just when you feel like, if you feel like you are well or your blood pressure look okay, and then you stop treatment. But having an insight about what the condition is did help in that respect. Then, so day to day, I lived a fairly normal life. A lot of people, around me didn't even know anything. I just all I took was blood pressure tablets before the COVID. But at COVID, that was when things really got worse. I got admitted to hospital, and I found that the kidney function had deteriorated quite significantly from about EGFR of about 40 something and going to about 20, going below 20. And we still maintain treatment. I was working actively as a consultant anesthetist in the hospital, and there were no. I didn't feel very unwell at all. There were no. I'm not diabetic. I didn't have any heart condition, which helped. All was left was for me to keep a close eye on what I eat. The diet that I had to make sure that I don't, the potassium level for it was very, very important, and the calcium level, and all the other electrolytes and feature that he's mentioned. Now, one aspect is the issue. Those of you who were there at the beginning, he didn't mention all the functions of the kidney, one of which is the production of red cells. Obviously, you get very tired as a result of a reduction in the production of red cells, and you became anemic. So, but once the EPO, which is one of the supplement, was given to assist, then that was an improvement. Again, I had to engage. You have to engage with that. You have to take the injections at the right time. They're just subcutaneous injection. So we carried on with that until, and I kept working until I had we got to a stage where we felt, oh well, you're very active, but the results that we are getting and meant that it was going to be very difficult for you to continue to cope. So it was suggested that we should have a preemptive dialysis. You just have dialysis twice a week to keep me going. So I engaged with that, but again, during dialysis, when I go to the dialysis unit, I see a lot of people. One of the things I observed was that, and for those of you who unfortunately find yourself in that situation, is that a lot of people might not actually understand what is happening to them. They might not understand what the various results are, and when the results are performed, as they do routinely, that they might not know what the figures. They don't understand the figures. So show interest in those. The nurses are very willing to explain. The doctors are very willing to explain. But you got to show interest in them so that you can cope. Because your diet becomes very important. What you eat is very important. So you have to keep an eye on that. Obviously, red meat is completely a no-no. And other meat products had to be very minimized. Obviously, a plant-based diet does help a lot, and it did help me a lot. So you need to keep an eye on that. So the next question you ask is, can you share your experience of the transplant process? Oh no, before that, you did ask also that how did I cope emotionally and practically and emotionally. Practically, Actually with dialysis, that was a bit of a challenge. I trained to for hemodialysis and to obviously to bring it home, but eventually decided I didn't want to have a dialysis at home. I wanted to have it in a unit, which was in Nottingham. And but I do the dialysis myself when I'm there. I connect the machines, and a lot of other people. You don't have to be medical to do that. A lot of people are trained to do that. Many people are able to do it at home as well. Um, but emotionally, well, that is where my faith comes in. My faith is very important to me, and we just had to believe. You have to believe that God is in it and He's going to help you. That things will be okay, and that's it. And I had a lot of people praying for me and praying for myself. Um, it does help emotionally for you to cope with the process and not and to see life from a positive attitude towards life generally. The next question is, you said can you share your experience of the transplant process from being referred and waiting to the surgery and early recovery, and what made the biggest difference to you? Yes, okay, when you're on dialysis, people are assessed whether they are suitable for transplant. There are various factors that are taken into consideration. Your general health, obviously, is quite important. Your cardiovascular status. In my own case, prior to this is where our clinicians and the physicians were very, very helpful. Even prior to dialysis, I was being asked to be prepped for possible transplant as much. And we went through all the processes, all the investigations were done, and then we were put on the list. And then waiting for when a suitable donor will be available. And that eventually happened. It wasn't a very straightforward, I think, with me, because there were two. It was on the fourth call that we found a suitable transplant kidney that was um, and I'm grateful to God. I'm grateful to all those who helped to care for me. By this January, I would have been 2 years, and I'd be quite completely well. There'd be no issues at all. I did not. A lot of the problems that people experience during transplant, during dialysis, I didn't experience it. I was very, very, very proactive in looking after myself, cooperating with the physician. I remember my physician saying to me at the time, well, he's found that there's a big difference between those who cooperate with their care and see themselves as a stakeholder in their own health, and those who don't engage. And if there's one thing, one advice I would give to those who find themselves in my situation, that is what it is. You have to engage, ask questions, read around the topic. Obviously, there's some misinformation out there, but clarify those information with your physicians before you begin to apply it to yourself. So once the transplant process was it's not as straightforward as people think. You just have a transplant, the next day you are jumping up and down. There's a process, and it takes nearly 9 months for you to be completely come to a state where you say you are very you can live a normal life. There's a lot of hospital appointments, but all that went through. There were readmissions to hospital. There were risk of infections, but you just have to have a positive attitude. Continue to engage with the process. Look at the medications that you are giving. If you have any symptoms, to ask questions. Don't delay. Ask questions. This is the way you are feeling, because what you might think doesn't matter does matter, and what you think matters might not actually matter as well. So that's very important. I know there are many people of faith on the platform. Sometimes people begin to think, "Oh, well, I'm praying," but prayer is very important. Believing in the scripture is very important, but the Bible also talks about wisdom. Wisdom. So wisdom is the principal thing, and wisdom in this case is following following the attention, following the advice you are giving, and doing the right things. It is not mutually exclusive. It is one and the same. My belief is that it is God that makes every process, every medical process, go through without complications. So you can pray into that, but that's not. It doesn't mean you disengage from the actual process itself. So that's in a nutshell. I think that's what I think. Those are your questions I've just said here. Like,
They were.
yes.
They were, and firstly, I thank you so much for sharing
Yeah.
your story. Really, really powerful, and you've just because of your unique intersection of faith, of being a clinician and lived experience, explained it with such clarity, but empathy as well. So thank you so much. And we have a lot of questions coming through. So I'm really eager to also bring Prof. Ibi on to go through. But just as we Prof. Ibi comes on, is just there a message that you'd like to give to others that are living with CKD, their families, or the professionals supporting them?
Yes, yes. In fact, I've just put that up there. It's, first of all, taking your health seriously and prevention, like we said before, does. Do not ignore medical advice. Okay, that's very important. Then be active, be an active patient. Just take regular exercises, all the things. You don't be a passive person. Then lifestyle choices. You got to watch your lifestyle choices. Things you do before, the things that are harmful, either the food you eat or the drugs like he mentioned earlier on, over-the-counter medication that can be quite damaging, or going on the internet and buying drugs from sources who say they will cure your kidney. You got to be very, very careful with those. And hope and health are powerful allies in healing. And that is what I best said before. Okay, when mercy and faith work together, and lives are restored. That's basically, like I've said, faith is trusting God, and wisdom is following the treatment.
Thank you so much. That is fantastic. So everyone, bear with me. I'm gonna zoom through because I have many questions, and I'll try and collate them as well. But I'm sure you'll agree we've had a fantastic morning so far. So Prof. Ibi, one of the questions that has come through is about people that are saying that their family members have kidney failure, etc. They've been told that. And they're then thinking, are there any tests that they should be asking as a family member of someone that's got kidney disease? What tests should they be asking their GP for to catch any problems early? A couple of people have sent something like that through. Oh, sorry, Prof, you're on mute. We don't want to miss a word.
All right, so thank you. Apologies for that. That's a very important question, and I do thank Dr. Nose for really sharing this this experience. And I always say that the patients who have the disease are the most powerful tools to encourage people who have the disease. And I always encourage patients to be advocates for to live with the disease. Now, yes, when you say there's a family history of kidney disease, what is the risk factor that led to the kidney disease? Like Dr. Nosa's case was due to glomerulonephritis, which is FSGS, when they did a biopsy. It didn't have any risk factors. But there's a link also genetically with FSGS in some patients, especially in the Black population. So if you have a family kidney disease, depends on the risk factor. So if your family member has diabetes, which means that, especially if you're older, type 2 diabetes, you need to look after yourself, work with your GP, primary care physician. And if you have high blood pressure in your family, that's something that you should pay attention to, that as you grow older, you're likely to have high blood pressure. And then kidney disease. So people you see with kidney disease must have something that has triggered it, so that's something that you should be aware of. Now, there are tests that are advocated, especially in the Black population, especially when we don't have any risk factor. One of the things that you tell your GP to do a simple blood test and simple urine test to see whether you have accumulation of toxins, maybe your creatinine is raised, but more importantly, to check whether there's protein in your urine. If there's protein in your urine, there is no cause for it, in which case, there are tests now available to check genetic predisposition to that, which is the APO1 gene and all that. But they don't get to that level. We get to do basic tests first to be sure, especially when you have a family history. But I said something important, that also look out for those risk factors. Are they present in the family history? So to answer, that's why the answer is not straightforward. But you can do basic tests. Go to your GP that have a family history. They will check for those risk factors, and they also check blood test, check urine test, and then take things from there.
Great. Thank you so much. And there, relevant to this, there was someone that's written that we know that so many Black people have high blood pressure and earlier than 40 years of age. And if this is the case, and the NHS message is health checks from 40 plus, and we get CKD earlier and likely stage 3, then isn't this a challenge for prevention of chronic kidney disease? And, not everyone will purchase a BP monitor before then to check their numbers. So just kind of tying in with what you said earlier, if you could reflect on that, please.
Okay, yes, that's very important. I mean, I'm very much aware that within the data from Nigeria, if you look at it, the other way around, hypertension is the commonest cause. I mean, all the Black young patients I've seen, those are the less than 35, don't even aware that they have high blood pressure. So if you look at the data, especially the data coming from low and middle income countries like Africa, Sub-Saharan Africa, and also if you look at there's a study called FRCP study that is studied among American Blacks. You see that the people are having at the younger age compared to Caucasians, right? And that's where they brought this concept that is a gene that is causing that, APO1 gene or something. Why, if somebody has hypertension at age 30, I would want to test them genetically for APO1 gene. Yeah. So to see, because if you have high blood pressure and then leading to kidney disease right away, then there's something that is triggering that progression quickly. So the answer, yes, in Africans is quite earlier than 40. But the question is that that's where we're talking about health inequality and equity within the NHS. And that's what CAN is always be advocating. That if they just generalize, then we'll be missing those people that are less than 35. So why don't we take specific groups, communities, to begin to say that, hey, look at this group. This is the data there. They should be looked at earlier. Not say that, well, it's above the general data that you see by WHO is at 40s and above. But we get people who are 30 years old that have high blood, very severe hypertension.
No, thank you so much. And I think so many things that you've said really resonate. And it links onto another question, and perhaps just to reference it, is that someone said, could genetic testing help identify predisposition to CKD? And you've mentioned APOE1, but I don't know if there's anything else that you want to mention.
Yeah, I mean, there's no other. This is something that this study has been done in the last 10 years, and we're still looking at it and looking at the link and trying to bring out medications for that. So the thing that I just saw another question which said, can you convince your GP to test it? If GP cannot test it because they're not funded to test that. Who is funded to test that is a kidney doctor, and we need to give a rationale. It's an expensive test. We don't give a rationale for it. And one would say that I've seen young Black patients who have severe hypertension and CKD. I insist that they do an APO1 gene test for me. Which that in context, we can say that, do you have other family members who can test? So those are the things that is a case-by-case
scenario. Okay, thank you so much. I am very aware of time, but I'm going to merge two questions into one. It's quite a big area, but if you could zoom through so I can hand over to Prince, otherwise I'll get towed off. But It's related to magnesium. You mentioned about magnesium, and you also mentioned about herbal medicine. And so people are asking, is magnesium good or bad? We all know that, magnesium glycinate around the perimenopausal area is coming out thick and fast. But also, people recognize some of the concerns you have about herbal medicines, and they're saying, where can they find people that can give them a better understanding of it if they want to bring that into their lives as well. So if you could just give a bit of an overview about magnesium and herbal reflections, and then I think we may have to end there with questions.
Okay. Yeah, thank you very much. Now, I just want to say the first message about for people with healthy kidneys, magnesium is generally safe and even beneficial. But too much can be harmful, especially for those with pre-existing kidney disease. Now, there's somebody that said she had transplant. Now, magnesium is a salt that is linked to many things. It's linked to calcium. It's linked to potassium, and so there's a very strong association within the way the tubules, the filters in the kidney work. So it's good. But you have also to know that there's an article that says that magnesium as a new player in CKD, too little is as bad as too much.
Mm-hmm.
Yeah. So if you go and take magnesium over the counter, daily intake of 250 to 500 milligrams is usually considered safe. But if you go and take loads and loads of magnesium and it goes high, it can damage your kidneys. That's the point I'm trying to make. So I put that there because it is important to know that.
Yeah.
So there are other things that with menopause, magnesium is it's good for the muscle, it's good for nerves, it's good for many things.
Mm-hmm.
But taking a lot of it can cause a lot of problems because if you take ferric magnesium, it will attract calcium because there's a link to it, to calcium, and all that. So if you kind of deposit in your body, it's not good. It causes vascular calcification and all that. So that is something that we should be aware of. So there's I'm not saying that magnesium totally is bad, but you have to take the right quantity. People go to buy Holland and Barrett and buy this. They tell them take one, they'll take three. I've seen people who are taking very high doses of this is women who are taking very high doses of vitamin D and say that it's going to be useful because they're premenopausal. You understand? So sometimes some of these things are important. Too little, and it's as bad as too much. So that's that question. Now, in terms of herbal medication, that's a real big area. We can talk about this for weeks. Go talk to Nigeria, go to any bus stop, you see that they're telling you it cures everything. So they give them all sorts. Right now, so there is this health lifestyle tips. I mean, I've seen very enlightened people, friends who have all sorts of things, who have hypertension. They take black seed, they take all sorts. They combine all of them, mash them with ginger, they crush them and drink them. They said, it is good. Well, if it makes you feeling good, it's kind of what Dr. also said, well, that's fine. But should be aware that some of these things with excessive take, it could damage your filters. I've made it clear because what filters those things in your blood when it gets into your stomach, it goes into the bloodstream. What filters it is the kidneys. And so the kidney membranes can be damaged. And that has been linked to some of these scars that happen in the kidney, which Dr. Dosa alluded to in terms of FSGS and things like that. So you see scars, which you can explain, that kind of thing. Yeah. I'm not saying that he took herbal medicines, but I mean, this could be primary FSGS, which is very technical word. So I don't want to go into the technicalities of renal medicine. Yeah.
I mean, what I would say, what the comment I would make about this issue of herbal products, it's not so much herbal products. It's a dieting situation. I'm a member of the American Society of Lifestyle Medicine, for instance, and we will look at nutrition for health and various aspects of the 6 pillars of health. There are lots of food that we can take that will improve our general health. Not necessarily kidneys, since a lot of antioxidants, for instance, a lot when you talk about ginger, turmeric, and all, they do improve your general health. And anything, I mean, there's a lot of inflammation around the body. But if you take a lot of drugs or food that have a lot of antioxidants, that will improve, it will reduce the damage to tissues and all. So that can be taken in moderation, and that is very important. People just need help to actually assess it. But what I will really be against is there are a lot of people on the internet selling drugs to you, tell you these are best, you take this, like he just alluded to, issue of overdose. I mean, too much of a good thing is bad for you. So we need to be aware of that. I took a lot of turmeric and ginger. My wife is I mean, she's not a doctor, but she knows everything about ginger and what it does to me. But initially, I was resistant. But when I investigated it from a medical perspective, I see some of these products are important, and you use it for your cooking all the day. Things like garlic, they will improve your overall general health, and of course, the kidney is part of that. Yeah. Yes.
Thank you so much. And I know we've gone over time, and I've been pushed. If you can bear with us for 2 more minutes, there are 2 questions that have come up repeatedly. I'm not sure if it's the same person sending it to me privately again in different wording, but I like your persistence if so. But there is a question about the implications of any of the GLP-1s, so the Mounjaro and Wegovy on kidney function. So that's one question. And there's another question on clinical trials I'll ask as a final question. But your thoughts about the weight loss drugs, please, and that also function as insulins.
Yeah, so GLP-1 has made a dramatic change, especially Mounjaro and semaglutide, which people are now switching to Mounjaro. In fact, dietitians are selling it on the internet. Right now, there's a crisis in the UK where patients can't get access to GLP-1 Mounjaro because all the ladies are going after this medication. I've had this patient where it's now limited even by prescription, that nobody will be able to give you that without a prescription. Now, Mounjaro is a good drug. I mean, it's one of the drugs that I've seen in patients who are overweight. For example, if when we're preparing patients for transplant and they're overweight, they are above the BMI that we should transplant them, we refer them to the weight management clinic. In fact, this is very interesting. The GP just wrote to me, I was just answering that. Is Mounjaro safe in CKD? I said, of course it is. So because we give it to our patients to prepare them for the to lose weight and all that. Now, what does Mounjaro do? You lose weight, and all the things that have to do with overweight, hypertension, diabetes, just crashes the percentage. So that means that it reduces your risk of having CKD. You understand? So, but the other thing I want to say that Mounjaro is safe in patients who have CKD. Let me put it like that also. There's no data that say that they're not safe. They're GLP-1, they're helping diabetes and all that. So everybody's taking it. Now, in terms of, right now it's used anyway, so people buy it over the net. My secretary bought it because she wanted to lose weight, so that's the thing. So it is not, but it is being abused now. People use it for cosmetic purposes, because they don't have any medical indication for it. I won't say that my own secretary was overweight, but she took Mounjaro because she wants to lose weight and be a certain size of dress or something. So I don't know whether that has answered your question.
No, thank you. That's great. And the very last question, and it may be that we'll have to just like 2 seconds, is about clinical trials. and Black people being part of them. So someone's written, and someone else has asked in a different wording, but as a community, we're already challenged by taking medicines, and so much we read to manage high blood pressure causes CKD. How do we know that the medicines work well for Black people? Are there trials or Black people part of the trials that have already taken place to justify use for Black people?
Yes, I did mention in my earlier presentation that one of the biggest studies in hypertension is a Framingham study that is in the States. And that's the biggest hypertension study in my memory. Yes, and so it is found that certain medications are less effective. For example, without being, using medical jargons, ACE inhibitors on its own are not effective in blood in terms of hypertension. That has been proven. And so if you look at management of hypertension by the NICE guidelines in the UK, they'll put there, if it is Black person, you don't start with ACE inhibitors, you start with calcium channel blockers like amlodipine, felodipine, and all that, except the patient is not tolerating it. And then other thing that is quite effective in our patients with Black patients is that our hypertension is driven by salt, because our kidneys kind of trap salt genetically. We can discuss that for many hours in terms of that. So that's why we use diuretics. If you look at, I remember when I was in medical school there in Nigeria, first thing they'll give you a thiazide diuretic, moderatic and all that. That was the first line of medication for hypertension. But those thoughts are changing because there's a lot of study there among Black people. Even in Nigeria, there's a lot of theological studies that have been done. So there are certain medications that are more effective than other medications, and it is there in guidelines. So your GP knows it. So they should not give you a medication that is not going to be effective for a Black person, because ACE inhibitors on its own is not effective. But calcium channel blockers, that's the first line for Black patients with hypertension.
Oh, wow. Thank you. That has been such a great session. Prof. Ibi, thank you for sharing all your knowledge, putting it forward in such an eloquent and clear way. Dr. Nosa, thank you for your lived experience, but also just your perspectives as a clinician and minister as well. It's been fantastic. And I just want to thank everyone that's been listening. It's the reason that these sessions are so successful is because of the questions that you ask. And so thank you for staying with us and listening. Apologies to the back-end team at Khan because I pushed us over a few minutes, but I think it was well worth it. So thank you all for your time. We don't take it lightly. And I just want to hand over to Prince, my colleague at Khan, who will kindly take us through some announcements before we all leave. But otherwise, have a lovely weekend, everyone.
Right. Thank you, Dr. Vanessa. Also, thank you, Professor Ibi and Reverend Dr. Nosa as well for explaining about your experiences and everything. My name is Prince. I'm the Faith and Community Outreach Worker for Khan. I'm based in London, so everything that has been said today is going to help me while I'm at the hub. Doing free sessions for people when they come in to do HIV screenings. And also we've started to do blood pressure tests and also blood glucose tests as well. So some of these, when they come into the community, they ask us some questions that we may need more, knowledge and information on. So thank you. This health hour is good because it helps us as well in the community to be able to, speak to people and feel more comfortable as well. So thank you so much. Okay. Right. Can we see my screen? Is it sharing?
Not yet.
Not yet, yeah.
Here it comes.
Is it sharing?
It's coming. Perfect.
All right. Okay. So our next health hour session is next week. Sorry. Yeah. And this session is going to be hosted by Dr. Itunu Johnson Shobetun. So this is going to be interesting as well. So it's about hormonal health throughout a woman's life. That's on Saturday, the 13th of December, 2025 at 11 a.m. to 12 p.m. So yeah, join us for a warm, honest conversation about hormones and Black women's health from first periods through pregnancy, menopause, and beyond. Yeah, so this is to register, you can go on info@khan.org.uk, and it's on the 13th of December 2025. So hopefully I see you there next week. The next one is Caribbean and African Carol Service. So the Caribbean and African Carol Service. So join us for a joyful carol service featuring choirs, candlelight readings, and festive music. The venue is going to be at Manchester Cathedral on Tuesday, the 9th of December, 2025 at 7 p.m. The entry is free, so reserve your spots now. For more information, events at khan.org.uk. Safer Home. So this is one of the projects that I'm on in London at the moment. So Khan has partnered with SGN, which is Southern Gas Networks, to bring essential support directly to Black, Caribbean, and African households across Croydon, Lambeth, Lewisham, and Southwark. So we're offering free carbon monoxide alarms and safety checks, energy efficiency guidance to reduce bills, income maximization support, priority service register assistance, which is good because this is one of the things that the people have been applying for to, to get them onto the register to get some free services. Also, if you'd like more information, you can contact us on saferhomes@khan.org.uk. So that's Safer Homes. Okay, Safe Steps. So this is the other project that I'm on. So join us for an online webinar dedicated to HIV awareness. So a safe space for people who want to be informed, gain knowledge, and take part in important discussions that uplift our community. So this is going to be online. It's going to be hosted by myself. So if you would like to be part of the discussions, you can join us as well on the 9th of December at 7 p.m. Rising Together. So this is North of England Leadership Conference on Thursday, the 5th of February, 2026 at 9:30 a.m. So healthcare professionals at all levels, nursing and midwifery students, senior leaders, policymakers, educators, workforce planners, and anyone committed to equity and inclusion. So join us on Thursday, the 5th of February at Manchester United Suite. Next one is Black-led counseling service. So this is culturally tailored counseling for Caribbean and African communities. We offer free counseling sessions designed specifically for Caribbean and Africa. Our team of Black counselors bring diverse backgrounds and deep understanding of cultural nuances, ensuring every session resonates with authenticity and empathy. To make a referral for yourself or someone you know, use our referral form. And finally, do you need support with any of these? So are you struggling with unsuitable housing and want to explore options? Unsure how to apply for benefits or what you're entitled to? Need help getting adaptations made to your home? Looking for support with your child's school or education, healthcare plans? Unhappy with your care package or a decision made by social services or the NHS? We can attend meetings with you in person or online, keep you informed throughout, and offer help in several languages. So the different ones we do is domestic violence and sexual abuse, advocacy service, home office sessions, family advocacy, and there's many more. Thank you so much for joining us today. We hope to see you all next week. Thank you, Dr. Faye. Dr. Vanessa, over to you.
No, thank you so much. And everyone have a lovely weekend. But thank you for the great announcements. And thank you for us.
Thank you very much.
Thank you.
Bye.
Thank you.
Bye. Thank you.
And that's our time for today. Whether you joined us on Zoom, Facebook, LinkedIn, or YouTube, thank you for making the Health Hour part of your Saturday. We hope today's session gave you the right dose of health wisdom that you can share with your friends and family. When we share knowledge, we strengthen our entire community. Mark your calendar. Next Saturday, same time. Got a topic in mind? We want to hear from you at health@can.org.uk. Health Hour, hosted by the Caribbean and African Health Network.